is visible? Is my slide visible?
Yes, sir. It's case one, visual.
Visual, right? All right. So I'm going to start the cases now. So this is the first case. I would like you to see the scan and give me the location of the lesion, then the differential diagnosis, the pattern of enhancement of the lesion, and the final diagnosis. So if you can see, I am presenting here a T2 weighted image here, a T2 SAG as a spine, a T1 SAG, corresponding axial images. This is a post-contrast T1 scan, and this is a post-contrast T1 in the axial plane. So we can start typing. Schwannoma, good. Harshit has called it schwannoma, sequestered dish. Okay, I'm getting some good answers. Please go ahead. First question, where is the location of the lesion? Where is it located, you think? In what plane? When we say location, I mean in what plane? Not able to see the slides, all right? Intradural, extramedullary, sequestered disc. IDEM, intradural extramedullary. So if you look at the axial scan, right, you see this is the thecal sac. You can see the thecal sac, it is being displaced by. So most likely it's an extradural lesion. Okay, it's an extradural which is having a both intracanalicular and intraspinal component. Okay, so this is most likely an intradural lesion. Fine. What are the other differential diagnoses you would like to put for here? Extramedullary intradural. Okay. Myxopapillary ependymoma. See, Sabina, the location of myxopapillary ependymoma is around the chorda equina, I mean the conus medullaris and the chorda equina nerve roots in the intradural location. This is an extradural lesion. Okay, so that's a differential, but not in this particular case. Anybody else want to put up for some other differential diagnosis? All right, so I'm moving ahead with the slides. Pseudodisc bulge. All right. So let's see. So this lesion is extradural. Okay. This lesion is extradural. It is located between the disc spaces of L3, L4 and L4, L5. Okay. And it is causing compression of the thecal sac, as well as it is showing extension along the neuroforamina. Neurofibroma is one differential by Kamlesh Kumar. And what is the pattern of enhancement? The lesion is showing peripheral enhancement. If you see, the lesion is showing peripheral enhancement, and the internal part is not showing any significant enhancement. If you look at the discs at other levels, they are degenerated. There is subtle degree of disc height reduction at L5, S1 level. The other discs are dehydrated. So this is the final diagnosis in this case is the disc sequestration. So my thing is, whenever you see a lesion in the extradural space between the two discs and which does not show intrinsic enhancement, when it shows a peripheral enhancement, do keep a differential of a sequestered disc in your list. So what is the next disc sequestration? It's a subtype of an extruded disc which has no continuity with the parent disc. Okay, so you'll not be able to see any continuity with the parent disc. So like this is an example where there's an annular tear and the disc is separated from the primary disc. This is an example of disc sequestration. So whenever you have a peripherally enhancing lesion in the extradural space, your differentials are a sequestered disc, definitely a nerve sheath tumor. So whoever has answered as a neurofibroma or a schwannoma, do definitely they are acknowledged here because this does stand as a differential diagnosis. An epidural abscess in an appropriate clinical setting, the patient has fever and all, and then presents with radicular pain, you can keep this as a differential. In this case, a diffusion will help you where it will show a restricted diffusion. And even an epidural hematoma, particularly patients who are on dual antiplatelet comes with swelling, most likely it is not in the neural foramina area, it is in the just behind the vertebral body where you can find an epidural hematoma. So this 4 differential you should remember when you have a lesion in this particular space. What is the pattern of enhancement? A peripheral enhancement of the disc fragment on contrast enhanced imaging study is due to the development of an inflammatory response with vascular granulation tissue on the periphery of the disc. So this is because of the inflammatory response and granulation tissue that you get this kind of a peripheral enhancement. So well done everyone. So this was a warm-up case, an easy case rather, and let's move on to the second case. This one is also a very easy one. Tell me the diagnosis in this particular case. What is the diagnosis here? So what I am giving you three images. This is a T1MP raised image. These two are the oblique coronal images of the brain. Okay, so what answers do I want? I want to tell me the diagnosis here, the primary diagnostic feature of this condition, how to acquire an oblique coronal MR, and what is this view that I am demonstrating you? What is this view on T1 image that I have demonstrated here? So Harshita has written mesial temporal sclerosis. I'm not happy with this because there are two sides of a temporal lobe. You should always mention which side, it's right or left. So this is, in this case, everybody is right-sided MTS is fine. So do you like to call it a mesial temporal sclerosis or a hippocampal sclerosis? How do you like to call it? See, hippocampal sclerosis is mostly a histopathological diagnosis. So we like to call it mostly a mesial temporal sclerosis because sometimes apart from the hippocampus, the other structures are also involved. So MTS is a holistic term. Better to use the term MTS. You're not wrong in calling it hippocampal sclerosis, but mostly it is reserved for a histopathological diagnosis. All right. Can people tell me the primary diagnostic feature of this condition? What is the primary diagnostic feature? So mesial temporal sclerosis has three primary features and certain others secondary features. Can anyone tell me the primary features of hippocampal? Atrophy of the mammillary body is a secondary feature. It is not a primary feature. Flare hyperintensity in hippocampus is a primary feature. That is fine. Then dilated temporal horn is not a primary feature. Anything else? Loss of digitations, interdigitation, asymmetric size. Okay, atrophy, flare hyperintensity. You're giving me two. Give me one more. Digitations, loss of internal architecture. Excellent. So these three are the primary diagnostic feature. Loss of internal architecture, an increased T2 signal of the hippocampi, and loss of volume. So excellent. How do you plan an oblique coronal sequence for an epilepsy imaging? Can anyone write it? How do you plan an oblique coronal sequence? Anyone has seen planning an oblique coronal sequence? Alright, no one is typing that. Perpendicular to the hippocampal lobe from sagittal. Yes, so you take a sag image first and you identify the hippocampus and then you orient your slides perpendicular to the hippocampus. So that is excellent. Then the fourth question, can you name this view? Can you name this view? This is the last. I think you have answered all the question. What is this view? Panoramic view. All right, it should have been called panoramic view, but unfortunately it is not called panoramic view. Anything else? So let me go to the slides. So you've answered, it's the right mesial temporal sclerosis. We have answered this So you've answered, it's the right mesial temporal sclerosis. We have answered this answered the question 2. So when you plan the oblique coronal sequence, this is how the oblique. Let me go to the secondary findings. Then I'll go to. So we have answered the primary findings. So secondary findings can be divided into temporal lobe findings and extratemporal lobe findings. So loss of hippocampal head digitation is a secondary finding. Dilation of temporal horn, temporal lobe atrophy, collateral white matter loss, and anterolateral cortex atrophy. These are secondary findings. And then there are some extratemporal lobe findings like a fornix atrophy, mammillary body atrophy, thalamic atrophy, and caudate atrophy. So temporal lobe, or you can see the atrophy of the temporal lobe itself. This is how you plan a case of a plan on oblique coronal sequence. You take a SAG image, get the hippocampus in view, and then you plan your sequences perpendicular to the line of the hippocampus, and that's how you get an oblique coronal image. And this view is called a Mercator's view. Okay, I'll come to the question, Ajmal. So this is called Mercator's view. Mercator is what? When you see the world map as a flat panel, it is called a Mercator's view. You open up. So if you do a curve multiplanar reconstruction, if you drawing these dots like this, multiple dots, you'll get this kind of an open book like appearance, and this is called a Mercator's projection. So this is a Mercator's view for hippocampal sclerosis. Now, if you ask me how to plan imaging for an MTS, so nowadays it's a world of 3D. You take a 3D T1, at least T1 MP range, you take a 3D flare, okay, and then you take oblique coronal sequences. In the oblique coronal sequences, it is a T2 which is the most important. And if you want to take a T1, if you want to take a T1, take an inversion recovery sequence. Now, why do you take an inversion recovery sequence? Because in inversion recovery, the white matter appears slightly hypointense, and the distinction between the gray and the white is accentuated. So whenever you take an inversion recovery sequence, the white matter signal is suppressed, and the distinction between the gray-white junction is accentuated, so that you can pick up a small FCD or something else. T2 relaxometry is not a primary sequence for all patients with epilepsy. All right. T2 relaxometry should be done only when you are suspecting a bilateral MTS and you're not sure about it. And like we have used it, we have not found it very informative. We do it only when we are having a doubt of bilateral MTS. Okay. All right. So this was well attempted.
Can you just wait for a few minutes? There is some connectivity issue. Just wait.
In fact, it's deep venous thrombosis, very good. So I'm impressed, very good. So let's see this particular case. What are the findings here? You see that there are symmetrical hyperintensities involving bilateral thalami. Then you have the involvement of bilateral cerebellar hemispheres, the vermis, the external capsule over here, the internal capsule is edematous, and there is central restriction in the thalamus, and you have bleed, which is involving the pontine tegmentum and bilateral cerebellar hemisphere. All right, donor sign of dengue, very good. Basilar top syndrome. See, if you would have had a basilar top syndrome, right, you would have had the medial part of the thalamus getting involved here, not the central thalamus. So the central thalamus is involved here. So the answer slide. So we have all described the findings here. It is excellent. Is my audio there? Am I audible?
No, sir. You are audible clearly, sir. You may continue.
Yes. So you can see this diffusion restriction in the thalami, which is central. So central diffusion restriction is not seen in a arterioaperture infarct. So the differential in this particular case is A&E. So excellent for those who have told A&E. Whenever you see a central diffusion restriction with a central bleed in the thalami, and you have a patient coming with fever and encephalopathy, do keep a differential diagnosis of A&E. Japanese encephalitis and dengue is known to involve bilateral thalami as well as cerebellum, like in this case, but hemorrhage in the cerebellum is predominant. Back. So if you see a patient, a familial case of AME, do get evaluated for RAN-BP2 gene. Okay, so RAN-BP2 gene is associated with familial cases of ANE, acute necrotizing encephalitis, and this has a very poor prognosis with mortality ranging up to 30 to 50%. So in this particular case, I would like to remind you that whenever you see bilateral symmetrical thalamus involvement with symmetrical cerebellar involvement with bleed, do keep a differential diagnosis of dengue. because nowadays it is becoming more and more prevalent. All right. There is something called a trilaminar pattern of diffusion restriction, which is described in patients with AME. In this, the central part is the hemorrhagic necrosis. So you don't see you don't see the restriction here. You see a hemorrhagic necrosis. It is bounded by a layer of cytotoxic edema and then another layer of vasogenic edema, giving a trilaminar pattern of diffusion restriction. So please remember this case. So is this clear? Anybody has any question regarding the diagnosis or anything you want to ask? Or I'm moving to the next case. All right. So I'm moving ahead with the next case. Case 4. A very simple case. 24-year-old female who has come with, tell me. Abscess. All right. Can somebody tell me where is the abscess located here in this particular case? GBM. All right. So GBM. So there are two abscess. So most of you guys are thinking about either it's an infective etiology or a malignant etiology of the left thalamus. All right. What are the major? If I tell you that this case is a case of an abscess, there is no doubt about it, because you have a very well-defined diffusion restriction in the center of the lesion, which is a classical for an abscess. Now, if you see here, what is a sign that is seen here? What is a dual rim sign? Can anyone tell me a dual rim sign? Good. DD60 GBM, central diffusion restriction. Excellent. Anybody can define me a dual rim sign here now? What is a dual rim sign? And on which particular sequence are we supposed to comment on a dual rim sign? Inner, high, outer, low, DI. Okay. Then anybody else? On GRE or on the SWI. So the sign was first described on a SWI sequence. Okay. Can anyone tell me why a dual rim sign is seen? Okay. T2 hypo, membrane like T2 hypointensity, that is in the outer layer on the inner layer, Kamlesh. Where do you see the T2 hypointensity? Necrosis plus edema, inner layer of T2 hypointensity. All right. How do you differentiate these two lesions based on the contrast enhancement? Excellent. Inner granulation, outer fibrous layer, NK. This is excellent. How do you describe the contrast enhancement in an abscess? So in an abscess, the contrast enhancement, is it thick or thin? It is thick. No. In an abscess, it will be a thin wall enhancement. In a GBM, it will be a thick and irregular wall enhancement. So let us go to the answer slides now. So, I mean, it is very simple that this is an abscess. Okay. You have a central diffusion restriction and you have a contrast enhancement. Whenever you see a contrast enhancement of a lesion suspected to be abscess around the ventricle, you always see that the ventricular part of the ring and of the enhancement is thinner than the outer part. Why is so? It is because of the vascularity. The periventricular area of brain is less perfused than the outer area. So there will be more inflammation in the outer areas and less inflammation in the inner areas. So there will be thinner wall. That is number one. What are the risk factors for the patients with abscess? Congenital heart disease, immunosuppression, taking immunosuppression agents, infective endocarditis, steroids, and all these are the. How do you differentiate a pyogenic abscess from a cystic glioblastoma? So a pyogenic abscess will show central diffusion restriction. It will show a dual rim sign on the SWI or the T2 weighted images. Presence of amino acid peak. Can anyone tell me the classical spectroscopy finding of a pyogenic brain abscess on a single voxel spectroscopy at short TE? Succinate peak, all right, Prabhakaran, then lipid lactate peak, then lipid lactate amino acid. Geeta, very good. So Geeta, can you tell me where do you find this amino acid peaks in a case of a pyogenic brain abscess? where I need to say at what ppm you find amino acids for a pyogenic brain abscess. 2.5 Shyam, 2.5. See, the amino acid that you get in yeah, zero point 0.9, zero point 0.9, excellent. So see, for a pyogenic brain abscess, what you get is a branch chain amino acids, which are usually resonating at zero point 0.9 to 1.3 ppm. All right. So that will be your branch chain amino acids. Then you get acetate at 1.9 ppm and you get succinate at 2.4 ppm. Just one word of thing that if you're doing a spectroscopy and you find that both the peaks are seen, you're getting succinate at 2.4 and acetate at 1.9. Okay, if acetate is the bigger peak, that is acetate is larger than succinate, it's a pyogenic abscess. And if succinate is larger than acetate, it's a parasitic cyst. A parasitic cyst will always have a dominant peak at 2.4, that is succinate. So succinate favors a parasitic, acetate favors a pyogenic. They are not mutually exclusive, but this is how you differentiate them. Now for the dual rim sign, if I can show you dual rim sign, this is a classical dual rim sign. You have an inner hyperintense rim of granulation tissue and outer hypointense rim of fibrocollagenous capsule. And whenever you see this sign, you are quite assured that you are looking at a pyogenic abscess. On the contrary, for a cystic glioblastoma, you will have this kind of irregular thick walled margin with lot of hemorrhage, and on contrast, they will show irregular and very thick contrast enhancement for a GM. Alright. So this was a case of a cystic lesion. So that's the pattern that you get in exam, cystic lesion or a cystic lesion with a Muller nodule. Let's move ahead with a different case. So this 35-year-old presented with headache, vomiting and diplopia. So please look at the images. You have a plain CT scan, a plain T2 image. This is a diffusion, all right, neurocytoma, or this is the ADC map. This is a post contrast. All right, everybody's writing neurocytoma. So this was an easy question. CPP. Okay, so the second differential has come around is choroid plexus papilloma. Okay, then central neurocytoma. All right. So based on the images, SEGA, very good differential, excellent differential. Okay, DDCPP. All right. So you guys have given me all the good differential here. Anything else which happens? CNC CNC na CNC grade 1 hoti nahi hai na? It is grade 2 only. All right. So based on the images, this is a central neurocytoma. Grade is a grade 2 tumor. What is the site of origin? Where does this tumor arise from? Where does central neurocytoma arises from? This was an easy question. CPP. Okay. So the second differential has come around is choroid plexus papilloma. Okay. Then central neurocytoma. All right. So based on the images, SEGA, very good differential, excellent differential. Okay, DDCPP, all right. So guys have given me all the good differential here. Anything else which happens? CNC, CNC grade 1 होती नहीं है ना? It is grade 2 only. All right. So based on the images, this is a central neurocytoma. Grade is a grade 2 tumor. What is the site of origin? Where does this tumor arise from? Where does central neurocytoma arises from? Subependymoma is also very good differential. Excellent. It arises from the septum pellucidum. Can you enumerate the differential diagnosis? You have already enumerated. So let's move to the answer. So definitely central neurocytoma, it's a grade 2 tumor. The tumor arises from the septum pellucidum. That is the glial cells which are lining the septum pellucidum. Okay, so that is the area of origin of tumors, and it is particularly near the foramen of Monro. And what are the differential diagnosis in this particular case? SEGA, you have already told. Subependymoma, you have told. Ependymomas, choroid plexus papilloma, and meningioma. So all of the differential and METs, I can also consider METs in differential, though they are rare to be intraventricular. Okay, excellent. So everyone has done very, very good for this particular case. And whenever you are having a doubt, you can look at these signs. Okay, central neurocytoma will have a broad attachment to the septum pellucidum. Look at this broad attachment of septum pellucidum, and at times you can have this fluid level within the tumor, which will help you for diagnosis. Or you can have a soap bubble appearance. That is, it will have a solid component with multiple internal cysts, and sometimes this cyst can be peripheral, which is called a peripheral cyst sign. So this different signs, if you get, basically it's a heterogeneous 17-year-old male presenting with uncontrolled hypertension. So based on the provided image, what is the likely diagnosis? First, tell me what are the findings here. This is a T2 weighted image. What are the findings in the T2 weighted image? Okay. Tell me the findings on the T2 weighted image first. What are the findings here? Caudate atrophy. All right. Then what are these lesions? Where I'm pointing my arrows 8. What are these lesions here? Chronic infarcts. Very good. So you have chronic infarcts involving bilateral basal ganglia and thalamus. What is happening on the SWI? What is happening on the SWI? No one is typing. Okay, so on the SWI, these are microhemorrhages. So you get multiple microhemorrhages in the area of cerebral peduncle, and maybe possibly a small area of SAH as well. Fine. What is happening? What is happening in the right ICA injection? What is happening? What is happening here? Which artery is this? Can anyone tell me? Which artery is this which is arising from the ICA? Which artery is this particular artery? This is not pica. Okay, pica arises from the vertebral artery. This is an ICA injection, so this is an ophthalmic artery. All right. What is this particular thing happening here? So this is an orbitofrontal branch. What is this small area? It's a microaneurysm. So you see a small aneurysm arising from a very small artery. Yeah, pseudoaneurysm you can call it. These are microaneurysms, and you have beaded appearance of the vessel. And this is a renal artery injection. What do you see? Multiple aneurysms here. All right. So this is the findings in the right ICA and the right renal angiogram. So what size of vessel are these? What size of vessel these are? These are medium vessel. Excellent. FMD is also a differential diagnosis. These are so all of you are correct. This is the diagnosis here in this case is a polyarteritis nodosa. And we made the diagnosis based on the beaded appearance of the right ophthalmic artery. I have shown you the microaneurysm arising from the orbitofrontal branch, and there were multiple microaneurysms in the interlobal renal arteries. So this is fine. So PAN basically is the primary medial caliber artery vasculitis, and it demonstrates segmental transmural inflammation with associated fibrinoid necrosis. Why does it happen? The vasa nervorum is involved. So most of the patient will present with peripheral nerve symptom, that is polyneuropathy, and rarely you will have central nervous system involvement. So mostly it is a peripheral nervous system which is involved, and rarely you will have CNS. And secondary pain, PAN, can develop in patients with hepatitis C or B infection, or in patients with hairy cell leukemia. All right. So this one was an easy one again. Case 7. In this case, the 71-year-old female presenting with left-sided hemiparesis. So I have given you a plain CT scan followed by a T2 edit image, followed by a diffusion trace image, a pre-T1 and a post-contrast T1 image. So Ravi Raj is saying it is a lymphoma. All right. Any other differential, any other mindset over here? And I've given you a spectroscopy also. Apart from Ravi Raj, Karan also feels it's lymphoma. All right. Anybody, any other alternate diagnosis, or you want to put a differential diagnosis here? Are you very sure? So everybody appears to be quite sure that it's a primary CNS lymphoma. What is the classical MR spectroscopy finding in this condition? Glioma is our differential. All right. METS is one more. Find glioma and METS. ठीक है, ठीक है, ठीक है. GBM and demyelinating. Okay. GBM. So GBM usually you have certain degree of necrosis, which in this particular case is missing. You have a small non-enhancing area, but this is not necrosis. All right, but yeah, as a DD, GBM is fine. So I'll tell you this case is a case of lymphoma. Why? I will go ahead further. Tell me the classical MR spectroscopy finding in CNS lymphoma. A large choline peak, all right. So a large choline peak is known, but if you have sometimes choline peak will not be there, and you'll find a large lipid peak. A large lipid peak and a large choline peak are the features of CNS lymphoma on spectroscopy. Why do you see restricted diffusion in primary CNS lymphoma? What's the cause of restricted diffusion in primary CNS lymphoma? It is highly cellular. All right. Because it is hypercellular, that's why you see a hyper-attenuating signal on the primary CT scan. You have a hypo-intense signal on the T2, and it shows diffusion reduction. Excellent. Everybody is doing very, very good. And you can give me 3 differential diagnoses. So all of you have given me a different diagnosis, but none of you mentioned toxoplasma. So if a patient is HIV positive, always remember to keep toxoplasma as a differential, because they also occur around the thalamus and they can show diffusion restriction. Invariably, they will have some degree of bleed within the lesion, which usually does not occur in lymphoma. Can anyone tell me a condition where in lymphoma there will be hemorrhage? So if you see hemorrhage in lymphoma, what does it suggest? A parallel question. A treated, excellent, post chemo, excellent, very good. That is one condition. Number 2, post chemo, post treatment, excellent. Tell me one more. You guys are doing excellent, so I'm quite impressed. Tell me one condition more where you can find post biopsy. Okay, fine. I'm looking for something else. Invasion of artery. All right, next, angiocentric lymphoma. Okay, then, so always remember, when you are talking about lymphoma, you can have a lymphoma, large lesions. All right, all right, all right, all right. Okay, okay. Okay, so let's move ahead then. Toxoplasma is a differential. Invasion of artery. All right, next, angiocentric lymphoma. Okay, then, so always remember when you are talking about lymphoma, you can have a lymphoma, large lesions. All right, all right, all right, all right. Okay, okay. Okay, so let's move ahead then. Toxoplasma is a differential. Okay. So you will have this condition. So it usually appears in single or multiple parenchymal lesions located supratentorially, okay, with a particular affinity to basal ganglia. So whenever you have lesions around the basal ganglia, corpus callosum, or the ventricular margin, consider primary B cell lymphoma as one of your differential. They are most common in the hemispheric areas, rare in the posterior fossa, and extremely rare in the spinal cord. We have discussed this hemorrhage. Somebody has written a differential toxo, GBM, tumefactive MS, abscess sarcoidosis. Excellent. Sarcoid, to have such a large lesion is little difficult. Generally, you have granulomas, but you don't get such large lesion. But okay, I take it. Abscess will not show homogeneous enhancement. Okay? It will be more of a necrotic lesion. So abscess to keep as a solid lesion is difficult. Okay. All right, so you guys again have done very well in this particular case. These are the different imaging features of lymphoma, mostly around the corpus callosum, MCPs in the cord. You can have this kind of ventricular wall enhancement, and when you have this angiocentric involvement or the angioinvasive, you can have this kind of appearance. These are called these are called intravascular lymphomas. You can have intravascular lymphomas when the lymphoma they try to travel along the VR spaces. All right. What is this? What I'm showing here? What is this curve called? Anyone can tell me how is this curve obtained? On perfusion. All right. So on perfusion, if you see the signal and the time curve, you see that this is a normal parenchyma, and this is in case of lymphoma, it overshoots the baseline. This overshooting of baseline on T2 star perfusion is known to occur with lymphoma. So whenever you have doubt, you can do a spectroscopy, and when you do an ROI, you can get this kind of time signal intensity curve. And this is because of T1 effect. So whenever you give contrast, the T2 star effect predominates. In case of lymphoma, a lot of contrast seeps into the interstitial space, and the T1 effect takes a upper hand than the T2 star effect. And so rather than dipping down, it overshoots. So this is the characteristic of lymphoma, which can help you in diagnosis. All right, and you get a high lipid peak on an elevated chorionic ratio. Case 8, again a very easy one. A 7-year-old boy with features of raised intracranial pressure. Complete diagnosis in this particular case. So you are seeing a T2. I told complete diagnosis. I told it's an easy case, so I know it's medulloblastoma. Give me a complete diagnosis. You guys are doing very good, so I expect you guys to answer better here. So you have this T1 image. This is a post-contrast image. Group 3 medulloblastoma. Karan, I'm impressed. Harshit, I'm impressed. But again, still your diagnosis is incomplete. Intraventricular medulloblastom. Medulloblastomas are invariably intraventricular. I mean, they are group 3, group 4 are intraventricular. With hydrocephalus, so I'll give you 1/2 mark extra, Kamlesh, but you still have to get some more marks. Medulloblastoma with hydrocephalus. Ependymal spread. Very good. So in this case, you have CSF dissemination. You can see what is this area? This is a supracellular cistern. You have this metastatic deposits over here. You can see this is leptomeningeal enhancement also. So there is CSF spread in this particular patient. Okay. So whenever you are seeing drop mets, excellent. So whenever you are seeing a patient with medulloblastoma, make it a point that you see all the cisternal spaces, all the sulcal spaces do acquire a post-contrast flare, and always screen the spine, so that you can see the drop metastasis and you don't miss it. You know, these medulloblastomas, they are diffusion bright. Ependymoma mets, good. So this, you've answered the question about complete diagnosis, you've answered the question about molecular type, importance of whole craniospinal axis imaging. I was telling a point that this medulloblastomas are restricting on diffusion. So if your scanner supports a SAG diffusion of spine, you can do acquire that, because even the drop mets will be restricting on the DWI. And differential diagnosis. So you guys have mentioned the differential diagnosis. So do keep ATRT as your differential if the child is presenting below 2 years of age. Okay, because ATRT can present manifest like medulloblastoma, but they have a earlier age group of presentation. Ependymoma, ETMR, these all are the differential diagnosis for this particular patients. So a little bit about the molecular subtypes. You can classify them histologically into 4 groups: desmoplastic, the classical type, then the desmoplastic type, medulloblastoma with extensive nodularity, large cell anaplastic medulloblastomas, and you have this. I think Achilles very well written over here, the different types of medulloblastomas. All right, now it is classified as FSH activated. Excellent, actually. So if you see the WN2, they are the rare, but they have the best prognosis, and they occur around the CP angle cistern and the cerebellar peduncles. The SHH group, they have a bimodal appearance. So if you see a medulloblastoma in the adult group, most likely it's going to be desmoplastic type. They have an intermediate prognosis, and they occur on the surface of the cerebellar folias. They occur on the surface of cerebellar folias. So sometimes you might think that it's an extra-axial tumor. They can be on the surface. And when they're intraventricular, it can be a type 3 or a type 4. An enhancement one is a type 3, and a non-enhancing one is a type 4. So Akhil, I am impressed. Very good. So, and you can always take use of the ADC maps when you're trying to report patients with medulloblastoma slash ependymoma slash pilocytic astrocytoma. These 3 are the most common differentials in posterior fossa tumor. Just to remember, the most significantly restricting one will be medulloblastoma, where the ADC values are around 0.76 plus minus 0.16. Intermediate, around 1 group is your ependymoma, and around 1.4 to 1.6 group is your pilocytic astrocytoma. So pilocytic astrocytoma, usually they don't test it. All right. So you guys are doing very good. Let us move ahead now with a little difficult cases now. So what are the findings here in this particular case? CVT Anupama. Okay. Enumerate the differential diagnosis, risk factor, and 5 differential diagnosis. Parenchymal hemorrhage, SAH. So if I tell you this is the SAH over here, what kind of bleed is this? DAI, excellent axonal injury. Very good. Very good. So you have 3 images over here. There are 3. This, what kind of bleed is it? Does it have a name? Developmental AVM. Hemorrhagic venous infarct, secondary to CVT, aneurysmal bleed, SAH. All right. Now, tell me the cashew sign. This is Ronak Purohit. Excellent. Geeta, excellent. So this is called a juxtacortical hemorrhage. A juxtacortical hemorrhage. And if you like to name everything, this is a cashew nut sign for you. All right. So you have 2 juxtacortical hemorrhages and 1 area of subarachnoid hemorrhage. I have given you a contrast image also, where you can see a filling defect within the superficial sinus. It's a classical picture of a CVT. Differential diagnosis क्या क्या बताया आप लोगों ने? So you have told about diffusion axonal injury. It's a good differential diagnosis. SAH because of aneurysm rupture, good differential diagnosis. All right. Risk factor for the entity: OCP intake, pregnancy, dehydration. Very good. Now tell me 5 differential diagnoses of convexity SAH. So remember, press cocaine CA. Okay. Convexity SAH के 5 differential बताइए. Cavernoma, it causes parenchymal bleed mostly. Akhil. Anything else? SLE, RCBS is very good. Amyloid angiopathy good. Pseudo SH, it's not SH by itself, Manisha. So can't take it as a differential pseudo SH. Okay, 2 बता दिए आपने, बताइए. diagnosis. SAH because of aneurysm rupture, good differential diagnosis. All right. Risk factor for the entity, OCP intake, pregnancy, dehydration, very good. Now tell me 5 differential diagnoses of convexity SAH. So remember press, cocaine, CA, okay? Convexity SAH के 5 differential बताइए. Cavernoma, it causes parenchymal bleed mostly. Akhil, anything else? SLE, RCBS is very good. Amyloid angiopathy good. Pseudo SH, it's not SH by itself, Manisha. So can't take it as a differential pseudo SH. Okay, दो बता दिए आपने, बताइए. Okay, दो बता दिए आपने, बताइए. Please see this case. What is the likely diagnosis here? This is a T2 weighted image, meningitis. It's a 3-year-old boy, okay? Spasticity, bulbar symptoms since birth. So this is a T2 weighted image. This is a T1 non-contrast image. This is a DWI image, and this is a post-contrast image. So people are writing leukodystrophy, Alexander's, then Krati and Ankit has written Alexander's. Can any one of you tell me why do you make the diagnosis of Alexander? Or can anyone try to describe the finding in this particular case? Anterior involvement, very good. So whenever you look at a bilateral symmetrical involvement, always try to do a pattern recognition. Macrocephaly, advancing lesion. So see, in this particular case, if you see, there is a definite anterior to posterior gradient. Means the white matter abnormalities are predominantly anterior than posterior. Okay, so this is an anterior to posterior gradient. You have involvement of the basal ganglia also in form of putamen involvement and caudate involvement. If you see the edges now of the ventricles, they are slightly hypointense, and on the plane T1 there is hyperintensity here. Can you see this hyperintensity? This is very, very important. And when you give contrast, this T1 hyperintense areas so intense post contrast enhancement. You can see also enhancement along the posterior part. There is no diffusion restriction. So a bifrontal involvement in a patient with macrocephaly with this kind of T1 hyperintense rim and post contrast enhancement is classical for Alexander's disease. The gene associated is GFAP, very good. So what are the 3 clinical forms of this condition? So like most of you told, this is a classical example of Alexander's disease. They can present in the infantile period, juvenile period, or the adult also. We have to remember that in each age group, the imaging finding is subtly different. Very good. So infantile, juvenile, and adult. And this is the post contrast that you're seeing. You can see this kind of peripheral enhancement. There are 5 diagnostic criteria. Extensive white matter changes with frontal dominance, which was there in our case. A periventricular rim with high signal intensity of T1 image. I showed you the periventricular rim. Low signal on T2 weighted image. The same rim, which is hyperintense on T1, appears hypointense on T2. Alright. Then abnormalities of the basal ganglia and the thalamine. So in this particular case also you see the basal ganglia is symmetrically involved, and there is contrast enhancement in the periventricular white matter. In adult, if you see, you will see that there is gross atrophy of the brainstem. So in adult, you will not get the classical frontal dominant appearance. Rather, you will see involvement of the brainstem. You see that there is significant atrophy of the brainstem, and this has been described as the tadpole sign. So if you see gross atrophy of the medulla and the cervicomedullary junction, do keep a diagnosis differential of adult onset Alexander disease in your list. All right. Okay. Chalo. Next. So we had a frontal pattern. Now we're moving backwards. We have a posterior pattern. So this 10-year-old child with, I'm not able to see the history. Yeah. What is the imaging finding here? X-linked ALD. Everybody's up there. X-linked ALD. Okay. What is the diagnosis you told? What is the imaging finding? Please describe the finding first. Can somebody describe the finding here? Please बताएं. The finding here, diagnosis is upfront, yes. Peritrigonal, okay. How do you describe it? It is symmetrical involvement of bilateral parieto-occipital white matter Very good. Periventricular lesion with involvement of the splenium of corpus callosum. All right. Showing layered contrast enhancement. Schomburg's John. Excellent. Ayush, who is this? Anushya. Very good. What is the etiology of this condition? Why does it happen? Like last time you guys picked up the GFAP gene mutation. So what is the etiology of this condition? Yeah. Okay, let us move to the answer slides then. Fatty acid incorporation defect. Excellent. So definitely the diagnosis is very upfront. It's an X-linked adrenoleukodystrophy. It is because of accumulation of very long chain fatty acids due to genetic deficiency in the peroxisomal oxidation of fatty acids. So if you see different kinds of leukodystrophy, you have storage conditions, you have mitochondrial leukodystrophies, you have aminoacidopathies. So like that, you have peroxisomal disorder. So it's a subset of peroxisomal disorder where there is mutation of this gene called ABCD gene, and there is accumulation of very long chain amino acids. Somebody's already described the Schomburg's zone, and on if you do a spectroscopy, you may find a decreased NNA and an elevated choline T. So can you have a frontal involvement in ALD? Like we saw Alexander disease, right? It had a frontal involvement. Even X-linked ALD can have a frontal involvement. There is something called a frontal variant of X-linked adrenoleukodystrophy where the same finding, that is periventricular involvement with genu involvement and this kind of peripheral enhancement, will be seen on the MRI. Okay, so you can also have, just remember, though 90% of the cases show this classical Pareto-occipital distribution, 10% can show a frontal distribution also, and that is called a frontal variant of ALD. All right. Okay. Tell me diagnosis in this particular case. We have 10 minutes left, and we can see more cases. Tell me. Yes. So a 13-year-old male presenting with weakness of bilateral lower lips. ADEM, MS, ADEM. Let us go with the description first. MOGAD. What is happening here? What is happening here? Where are the imaging abnormalities? NMO, MS. Okay. So you have this patchy involvement in the pontine area. Then you have long segment myelitis, right? You have long segment myelitis. It is starting from the C2 vertebra, reaching till the conus medullaris. So this longitudinally extensive transverse myelitis. What is this bright line that you see over here? What is this bright line that you see over here? What is this bright line that you see in the center of the cord? Syrinx. Okay, so something which is appearing as bright as Vanita is thinking it to be syrinx. So this is called a sagittal line hyperintensity. Sagittal line hyperintensity, आपको याद रखना है अभी से. So whenever you see a long segment myelitis extending the entire cord, involving the conus medullaris and appearing like a pseudospinal canal. Okay, this is because the central part of the cord is involved. It is the classical for MOGAD. This is called sagittal line hyperintensity. It is looking like a prominent central canal because of a sagittal line hyperintensity. This pattern is very, very classical for MOGAD. Okay, DD is transverse myelitis and see, I would never keep multiple sclerosis as a differential diagnosis in this case. Multiple sclerosis, you will have the classical supratentorial lesion, which is around the ventricular margins, around the subcortical white matters, okay, callosocaptal interface, and short segment involvement. Excellent. So how do you define a long segment and how do you define a short segment? Can anyone tell me how do you define a long segment? Yes, more than three or more levels of vertebral level of cord involvement is defined as a long segment. Okay, so you cannot call it, so this is a long segment and short segment will not be more than 2. All right. So my next question is two most significant different diagnoses. You guys have already told me that. What is the involvement pattern of optic nerve in case of MOGAD? Can anyone tell me what is the pattern of involvement of optic nerve in patient with MOGAD? It is an anterior involvement. Bilateral symmetric anterior involvement is more commonly involved. Very good, disc edema. Excellent, Geeta. Disc involvement, disc edema, or a papilledema being evident on the MR is a feature of MOGAD. And area posterior syndrome is characteristic of this condition. True or false? Will area posterior be involved in MOGAD? Classically, no. I mean, nothing is 100% in medical science, but if that question is like this, answer is no. It is classical for NMOSD. All right. So we have already discussed the findings over here. These are the differential where it talked about NMOSD, ADEM, and sarcoidosis. Will not keep MS as a differential in this particular cases. There is bilateral anterior involvement, and we have discussed. All right. So another simple case. Tell me. We have 5 minutes more. I will show you two more cases. 8-year-old with non-specific complaints. What is this? This is Potterman. Just tell me the diagnosis in this case. A DVA. What is the full form of DVA? What is the full form of DVA? What does DVA stand for? Hypotension. All right. Developmental venous anomaly. Excellent. So this is a developmental venous anomaly. Now tell me, what are these small veins called? What are these small veins called? Medusa. So these are the medullary veins. These are small medullary veins which forms the hair, the medusa hair. And what is this vein called? What is this vein called? Tau sign is classically described not for this case. It is described for something else. So tau sign is described when you have a Ankit, can you tell me where is this tau sign described? Exactly, in a persistent trigeminal artery. Excellent. Tau sign is for the PTA, and this is not a, this is a vein. So this is a collector vein, and these are the medullary veins forming a developmental venous anomaly. So what is the most common presenting symptoms of this condition? What is the most common presenting symptom here in case of a DVA? That's an association. What is the most common presentation? So 98% of the patient will be asymptomatic. Patient will come for imaging for something else. It will be an incidental finding, and rarely in 2% cases they can be associated with cavernoma, and they can come with a hemorrhage also, particularly in the pediatric population. So mention at least one important association. Cavernoma, you have told me. And is this condition seen on DSA or not? If I do an angiogram, will this DVA will be seen? No, Kamlesh. It will be seen. See, it will be seen. Veins are always seen on an angiogram. It only in the delayed image. Very good. And cavernomas otherwise, cavernomas will not be seen. So remember, cavernomas are angio-occult. However, DVAs are seen on the angiogram. So I have given you a good diagnostic cerebral angiogram where you can see the cavernoma. This is the medullary veins. This is the collector vein draining. This is a classical example of a on an angiogram. So 98% are incidental, 2% will have hemorrhagic venous infarct. Most common associations are cavernomas, sinus peritonei. Because it's a developmental malformation, it can also be associated with cortical malformation. One malformation is always associated with other malformations. So remember, DVAs can also be associated with cortical malformation. You can have HHTs or blue rubber blab nevus syndrome. Angiographically, the caput medusa appearance, okay, is classical for this diagnosis. All right. I think I have 3 more minutes, so one more case for you. A difficult one or rather a very easy one? Tell me. So what are the blue coded tracts here? In image A, you have a blue coded colored props bundle, corticospinal tract. So what is this blue colored tract? And then you have to identify the task activation here. What is the task being done here? So this is the corticospinal tract. So in case of DTI, you have a universal color coding. Okay. The superior inferior directed fibers are blue in color. So like corticospinal tracts, yes, projection fibers, they come from top to down. So these will be colored blue. Okay. The interhemispheric fibers will be colored red, that is the crossing fibers, and the fibers connecting the same hemisphere will be covered green in color. If you see here, this is the hand knob area. So this is a motor task activation. Okay, so this is a tumor over here, most likely meningioma, showing a activation of the left motor cortex area. Full form of bold is blood oxygen level dependent. Excellent. So it's the blood oxygen level dependent. And mention the why do we do a task based fMRI? Mostly it is a pre-surgical thing that we do for localization of eloquent cortex, and most commonly you will be asked to do for 3 or 4 reasons: to identify the eloquent cortex, whether it's a motor area or a language area, or to identify where the memory is located, and sometimes the visual cortex. So these are the 3 or 4 indications that you will be asked to do. At least one, yeah, at least 1 centimeter distance. If it is there, the surgeon is very confident that the tumor can be completely removed. All right, can we take one more case? I think I'll stop here. I think I'll stop here. It's already time. So I hope you guys have liked. We discussed 14 cases in last 1 hour. You want to take the case? Okay, one more. So identify the stage of the bleed. So I have given you a T2 weighted image, a T1 weighted image, and this is a trace image, and this is a ADC image. Tell me which stage of bleed is it? In exam, if the examiner starts asking you about the stage of bleed, and if you answer, you're going to get very good marks. So everybody is saying an early subacute bleed. All right. How do we explain the DWI signal in this case? Match hemoglobin. Excellent. How do you explain? Now, if you see this, the DWI is showing a black finding. So what is this black representing? Why is the DWI signal black? This is my question. Why? So let me ask you a question in a different paramagnetic. Let me ask you a different way. In which stage of intraparenchymal bleed do you see diffusion restriction? Which stages of Gita has told T2 breakout effect? I am heavily impressed. Very good. So this black signal here is because of T2 blackout effect. Now my question was, in which stage of bleed does the DWI restrict? Somebody has written hyperacute, that's the correct answer, and also in the late subacute phase. So 2 phases, you will see diffusion restriction. Now this is for book. Always remember, blood always restricts. Blood always restricts on DWI, but the signal is dictated by the T2 weighted image. So if you have T2 blackout effect, that will mask the diffusion restriction. Like in this particular case, it is, if you see, the periphery is actually restricting. It is the T2 blackout effect that is predominant. So in whichever phase, like in acute phase and the early subacute phase where T2 is hypointense, you'll get a hypointense signal on the DWI. Whereas in the other cases where the T2 is bright, you will get diffusion restriction in the. I hope I have not confused you. This is a little bit of the physics thing. Hope you understand. What is the cause of T1 hyperintensity? Max hemoglobin, excellent. Now give me 5 different diagnoses of T1 hyperintensity in brain. Protein, fat, melanin, more. 2 more. Protein, fat, melanin. Protein, fat, melanin, blood. Okay, one more. Gadolinium, cholesterol, excellent. Mucin, very good, very good. I am actually impressed. So regarding, somebody told me to repeat. So see, it is very simple. Blood always restricts on DWI, but you see what is the T2 signal. Okay. So diffusion is a T2 weighted image. If something is black on T2, it will produce a blackout. Like in this case. So for exam, you may say whatever you want. You can say a hyperacute blood or late subacute blood restricts. Physics wise, it restricts everywhere. Wherever the signal is T2 black, the T2 blackout will always be the dominating sign that you see. Again, I don't want to confuse you guys. All right. Okay, it was quite amazing. I mean, taking this class. I loved it. Okay, thank you. Can I stop sharing? Can I end the session?